Thanks so much, Olga, for inviting me and and giving me the opportunity to talk about something that we've been thinking about for the last 5 or 10 years, really. So today I'm going to summarize some information briefly on MOG IgG associated disease. Just see, I'm having a little trouble again. Oh, there it is. These are my disclosures. My objectives are really to talk about the background of MOG antibody disease as a relevant new diagnostic category, and then to talk about distinctive clinical and neuroimaging features of MOG-related disorders, then move on to talk about newer findings focused on structural abnormalities in these disorders. And I'm going to start with a case. This is a case of a 2-year-old child, and this is a case that any of us might have seen in the emergency room or on the ward. He presented with a focal seizure. He had mild encephalopathy, a little bit of, the parents noticed that he was not speaking appropriately, but overall looked bright and happy. He received the MRI scan of the brain because of slowing on his EEG, and it showed this. Which is, as you can see, multifocal abnormalities on the scan, which are diffuse. It showed there's an abnormality here on this cervical, in the spinal cord, and which is a holocord. I'm sorry, I'm having a bit of a technical problem here. I apologize. Which is a longitudinally extensive lesion with a holocord abnormality. And so, in talking to the family, really, what you want to be able to do is to adequately talk about diagnosis and risk of recurrence. And in other times, you might have used a purely phenotypic description and say that the child might have acute disseminated encephalomyelitis, and go on to say, well, I don't know if this is going to be a recurrent disease or a monophasic disorder, because some children with an acute disseminated encephalomyelitis might have been found to have multiple episodes, which some people might have entitled multiphasic acute disseminated encephalomyelitis or recurrent acute disseminated encephalomyelitis. And as you all know, there was debate over whether these people who had an initial ADEM phenotype fit in with those who had multiple sclerosis, or if they were a completely different thing. And today what I'm going to talk about is how MOG IgG fits in with this, this large picture of neuroinflammatory disorders and demyelinating disorders in children and in adults. As you all know, myelin oligodendrocyte glycoprotein has been of interest for quite some time within neurology and within MS. It's something that's found on the surface of myelin and oligodendrocytes. And in animal models, it's been found to be an autoantigen for T and B cell responses. Importantly, and we all know this, those of us that have been in the MS world for a long time, antibodies to MOG are linked to demyelination in animal models, which really confirms the pathogenic potential. Importantly, although people were very interested in this for some time, discerning whether or not this was a relevant antibody for disease in humans didn't really come about until the development of newer cell-based assays developed in different places in Europe, in North America, in the UK, but in the last 10 years, it's been very clear that the newer cell-based assays have identified a specific subgroup of patients with demyelinating disorders. So what is the epidemiology of this? People are talking about it all the time. And in fact, it's relatively infrequent in the population, but is frequent in the children that we take care of with neuroinflammatory disorders. The incidence, very few incidence studies have been performed, but it's been found to, at least in a very nice study from the Netherlands, found to be found to occur in about 0.16 per 100,000 population per year, with children representing a larger number and a greater proportion of those who are MOG positive. In fact, in children, it's children are 2.5 times more likely than adults to be positive for MOG antibodies. Taken another way, thinking about this, pediatric demyelinating syndromes occur in about 1 in 100,000 people per year. And of those, about 20% are MOG positive. I'll show you some information about that in just a minute. So 20% of 1 in 100,000 are going to be MOG positive within pediatric demyelinating syndromes. But even more importantly, those children who have relapsing disease, who are aquaporin 4 negative, are highly likely to be positive for MOG antibodies, suggesting that this is a highly relevant antibody for disease and for specific phenotypes of disease. So what is the significance of a positive serum? There's been a lot written about positive MOG antibodies. It's coming out more, but one of the important issues to consider is whether or not the antibody continues to be positive in the blood. I'm just showing you this to demonstrate within our population the numbers that we see. So as I said earlier, about 20% of children are positive for MOG antibodies, which to me it's the most frequently positive antibody that we see in our population. But importantly, many of them are transient, and those that become negative within 3 months represent almost half of the population. And if you look further, it's very clear that of that 22% of positive patients, only about a third will end up with recurrent disease. So the positivity is significant and important, but you need to pay attention to whether or not it persists within the system. And this has been shown by many other people at this point. So does it show a specific phenotype? Does it demonstrate? Does MOG associate with a specific phenotype? Julia Longoni, who's in our group, has looked at this, and in the pediatric population, it appears that any patient with an MS diagnosis is highly unlikely to be MOG antibody positive. And those with other phenotypes of neuroinflammation, such as NMDA, which was described in the talk before, are also unlikely to be positive for MOG antibodies. Yet, those who have those who have demyelinating syndromes, as identified as optic neuritis, transverse myelitis, and those types of things, acute disseminating encephalomyelitis, are very likely to be positive for MOG antibodies. And in fact, in our cohort, we have 42% for MOG antibody positive. And going back to the question of how relevant positivity is for predicting relapse, what we see here is that if you are negative by 3 to 6 months, the negative predictive value for relapse, meaning the lack of relapse in the future, is high. Whereas if you remain positive for 6 to 12 months, it is going to be more highly predictive. That's sort of the sweet point for predicting whether or not you're going to have relapses. So important. The bottom line there is even if you get a positive right at onset, it is important to consider doing a repeat MOG antibody test, and probably doing that at 6 or 12 months to see if it remains positive. So what are the clinical phenotypes that are seen in this syndrome? The majority, if you go back to the slide that I started out with, we'll start off with, in the pediatric population, we'll have an acute disseminated encephalomyelitis presentation. 66% of children with an ADEM presentation will be MOG positive, and about half that present with an ADEM presentation overall will be MOG positive. Pediatric patients are different from adult patients in that the ADEM phenotype, as you guys know, is less likely to be seen in the adult population, and in fact, much less likely. So an ADEM presentation occurs in only 6% of those who are MOG positive who are adults. And looking at other studies, the issue of cerebral symptoms, which is the encephalopathy that we often would talk about in relation to acute disseminated encephalomyelitis, occurs really only in 23% of adults versus 2/3 of pediatrics. But the optic nerve is really where the money is. Half of adult patients and half of pediatric patients will present with optic neuritis, and patients with MOG IgG positive. Flip the other way, if you look at children with optic neuritis, half of the patients that present acutely with optic neuritis will be MOG IgG positive. So that's pretty good value for checking your MOG IgG in these patients. Now I want to talk a little bit about the visual pathway now because it's such an important part of MOG antibodies, and I want to remind you of what the optic nerve looks like in these patients. The optic nerve in people with MOG antibodies is generally, at least in the pediatric population, will be swollen with a retinal nerve fiber layer thickness 2 to 3 times normal. And here you can see the great degree of swelling with atrophy, marked atrophy within 6 months of the first episode. So large swelling, marked atrophy in the nerve. We looked at this previously in children who were likely MOG antibody positive, and here we demonstrate, it just demonstrates that the marked decrease in retinal nerve fiber layer thickness from 100 to 67 and 100 to 50 in children fitting in the phenotype of MOG antibodies. So the eye is very important, and structural abnormalities in the eye are very important in children with MOG. We asked the question of whether those structural abnormalities could help to predict MOG antibody positivity using a machine learning approach with a supervised learning approach. And found, and this is work of Beza Sipsi, who is a fellow in my group and now is in Winnipeg, and found that we could that using this algorithm, with 85, we could predict MOG antibody disease with 85% accuracy using structural visual metrics and clinical metrics. So not bad. So it appears that there is something very special and very typical in the eyes, and that we could potentially take advantage of machine learning metrics in the future. Not only are visual pathways affected in the anterior visual pathway, but we went on to ask the question of whether or not visual pathways were affected in children with MOG in relation to children with MS and in relation to typically developing controls. And this is a picture of gray matter of cortical thickness in children with MOG on the right in comparison to typically developing controls, and MS on the left in comparison to typically developing controls. And I want to highlight the V1 area in children with MOG that seems to be preferentially affected in MOG and doesn't seem to be so much affected in MS patients. In addition, so this is work of Sonia Bells. This is cortical thickness. Sonia also evaluated white matter and asked the question of whether fiber density was different in typically developing children versus MOG, and found that in the right optic radiations, there were abnormalities in MOG patients that were prominent. So we have a signal from the visual pathway, not only from the anterior visual pathway, but in the optic radiations and in cortical thickness at V1. Thus, evaluation of the visual pathway may help us to understand MOG-related disorders. Now, going back to the original question that we started with, can we predict recurrence? What can we say to families when we see a patient like this? Well, it's clear that antibodies make a difference. It's clear that the visual pathway is important. Do we see any degenerative changes like what we see in MS patients? So this is just early work, but I wanted to share this with you because I think it's really important to think about, because those of us in the field who've taken care of children with acute disseminated encephalomyelitis in general have been very positive about these children, and have also thought that even in the kids with recurrent disorders, that they did very well. This is early work from Giulia Longoni, who is a new staff member within our faculty, where she looked at myelin volume fraction and axonal volume fraction in children with recurrent MOG disorders versus MS patients versus healthy controls. And what she showed here, I want to highlight, these are the MOG patients right here. And what she showed was that disease duration, that the myelin volume fraction acted just like it did in MS patients, in MOG patients, even though the fraction was different, the direction was the same. Disease duration is on the x-axis here. And the same directional rule applied for axonal volume fraction, suggesting that there are axonal myelin abnormalities that are associated with disease duration in MOG. So this is early work. We need to look longitudinally, and it's just the beginning. So what are you going to say to the family? What is going to happen to the child? What is the risk of recurrence? Are there things that that we know now about the trajectory of the children? And I think that we can say that we know a little bit more, that that MOG antibodies would be relevant for a child like this, and it would be relevant, that they are relevant for the adult and pediatric population. We would be able to tell the family that recurrent disease represents 1/3 of cases who are initially positive. So even if the child was positive, we still need to wait. And that the pattern seen in that child is very common within the pediatric population who are MOG positive. Although in the adult population, we're more likely to see optic neuritis presenting. And finally, that the visual pathway is very important to pay attention to and will provide important information on MOG-related disorders. And I'm going to wrap up there. There's my team. I want to thank my team for all of the support and help, and I'll wrap it up here. Thank you very much for your attention.
Thank you, Ann. Virtual clapping. Excellent presentation, very comprehensive. Thank you very much. I think we have time for 1 or 2 questions. If people have questions, please use the link at the bottom of your slide if you want to ask a question. While people think about a question, I can ask you, so in your children, do you check the MOG antibodies if they have optic neuritis, or you do only if they have ADEM kind of presentation?
Yeah,
or considering the high specificity of the antibodies,
yeah.
for adults with thinking of using more and more just routinely at the onset of optic neuritis?
Yeah, so because it's going to be, there's a 50% chance that it's going to be positive, and in our optic neuritis patients, we do send it in all optic neuritis patients. But those patients who have optic neuritis alone with no brain lesions are still going to be likely to have the antibody become negative within 3 to 6 months. So we still send it, and it's still sort of a developing story. But it is, I think it's actually quite important in this population.
Yes, thank you. And do you use the MRI to help you a bit in the differential diagnosis between non-ADEM MOG and MS on a patient-by-patient basis? You've shown the lovely pictures on population level, group level analysis. Do you have any insight in using MRI for individual cases?
Yeah, absolutely. And so what we found, and this has come out in the sort of emerged in the as we've learned more about this, is that the older children who have a very clearly, typically MS-like pattern, meaning Dawson's fingers, corpus callosum lesions, fluffy lesions, will be very, very unlikely to have MOG antibodies. On the other hand, those kids with large lesions, large fluffy lesions, longitudinally extensive spinal cord lesions are highly positive. And so we actually do use the MRI. Something funny has happened this year, though, and it's probably related to COVID. Some of the kids that I predicted would be MOG positive are not. Ones that have disseminated, diffuse lesions. And it makes me think about, it has made me really think about the pathophysiology or the trigger that is required for MOG. We've seen fewer MOG cases this year in our cohort, and I think it's related to the lockdown. But we've seen more MS cases in younger children, and I'm sure they're MS. So, I think the MRI is really useful, but it's been less useful this year.
Yeah, interesting. Yeah, very interesting. So thank you very much. Thank you for taking the time and accepting the invitation to present